they have a program scheduled, online program scheduled for 2 o'clock. We'll try to do our best to be efficient in understanding what, I guess our goal here on ahead is what's the word? We are live.
Okay.
Aaron's on top.
Aaron's on top.
Aaron. So we are live. So we're back, and this is the Healthcare Reform Oversight Committee, the continuing meeting. As I said, we're a little bit late. We'll try to finish by 2 so that folks who need to be somewhere else can be where they need to be. We are talking about the future of payment reform, the AHEAD model. We're looking at what work is underway currently. How does it factor in with negotiations with CMS, what's happening there? What's the future of payment reform look like in Vermont with and without participation in the AHEAD model? I know there's a lot of controversy around AHEAD. Some people think we should do it, some don't. The pros and cons are out there. So this will be an opportunity just to get our feet on the ground with where we are and then ask some of those important questions. And I do have a question actually related to what we heard this morning, and I'm going to ask it of Chair Foster. You don't have to answer it right away. I just want to get it out to you. It was an interesting conversation about some of the work that's going on now with hospitals, and they're already beginning their own transformation. So they're already changing services, and there might be some money. When those changes are made, and if they work in collaboration with other, the way Senator Westman was talking earlier, working in collaboration with other entities like an FQHC, how will global budgeting take all of that into account, if at all, and how does that sort out? That's a bigger question, but it's one I think residual from this morning that might, from your perspective as a regulator, would be helpful to at some point hear about.
You can give a high level, if that's helpful.
Yeah, you have a minute. Very
15 seconds. It depends on the methodology that you use, right? So there are service line changes in the methodology that we submitted as a draft to CMS. And there's different things that can happen. Why is the service line being changed? Service line increases, additions, all of that is reviewed under the global budget methodology that we submitted. The global budget methodology can change if we go forward and if we want to, or we can use a hybrid model or the off-the-shelf model. So it all depends is the answer on what the ultimately is.
Okay, thank you. So there is an effect. Is that for all hospitals in the state of Vermont?
As the secretary will speak to, I'm sure we're not sure how many would sign up. We're not sure if it's a voluntary, mandatory, like when it's voluntary, when it's. So that's also a big unknown at this point. If a hospital is not in a global budget, it would not have that. It would be in the ordinary budgetary process. And of course, you might have. There's no expectation or anticipation at this point that you'll have a commercial global budget if you go forward with the first year of the model. So you'll have two systems. You'll have a global budget system for the Medicare component and then the ordinary system for the fee-for-service component. That would potentially switch if we go forward with the model and stay in the model.
Okay, good. We might come back to this one then. Great. So it's all yours.
So I think for the record, just to be formal, I'm Jenny Samuelson, Secretary for the Agency of Human Services, for those folks who weren't here this morning. What I'd like to start off with, what I'd like to start off with is acknowledging that there's some level of fatigue in the conversation about models and in the conversation about payment reform because of the length of time that we've been doing this work and from the all-payer model. I think we can acknowledge that there were things that did work and things that didn't work in the current all-payer model. that we are trying to take into consideration as we're negotiating the next model. Some of those include, for things that did work, increasing support for providers like independent primary care, sustaining Medicare support for Blueprint and STASH, funds redistribution in a small part to some of our community-based providers, and public and private sector coalescing around some key ideas. I think I've touched on some of the things that didn't work this morning. A lack of multi-payer approach. We said it was going to be a multi-payer model. We ended up having very little participation of commercial insurers in it. The model for Medicaid and for Medicare were also vastly different, something that we're going to try to correct in the next model. There were multiple activities that changed over time and may have hindered a focus. We talked earlier about how important it's been over the last 2 years to really focus in on advancing key areas that didn't happen in the all-payer model. There was also an all flowers bloom approach, where it was a grant here and a grant there without thinking about sustainability. So these are just some of the, I don't want to read all of them, but some of the key learnings that we've taken into the next model. I do want to, so when we think about Medicare, this is how they view the model themselves. And so I'm going to walk us through it through their vision because it helps us to identify the components of the model. The first piece is that they believe that will create statewide accountability. So essentially, similar to our Medicare program, we're taking accountability for keeping healthcare costs for Medicare under a Medicare total cost of care and for the overall statewide total cost of care. That is similar to our current model, except in this model, we have the potential for taking and moving some of those investments back into the state if we're below the total cost of care. The second is that CMS is moving, the second is that we have a primary care investment target. They've identified that we need to increase the amount of funding that is going to primary care. And so that is a key focus in this model. And they want us to create transformation and equity plans based on outcomes in Vermont that will help to drive change. In order to support that, they're putting funding in a cooperative agreement, which has already started, that will help support some of the infrastructure costs. It's not going to be enough, but it's at least Medicare's portion of that. It creates a hospital global budget, which will go into more detail, and a primary care payment methodology that aligns with increasing payments going to primary care and aligns with our Blueprint standards here in Vermont. Their core components and strategies is they want to see additional investment in equity. They want to ensure that we're addressing, and I apologize for folks, this is their slide. They say behavioral health. I clearly understand in Vermont that that's offensive, and we're talking about substance use and mental health here. All payer approaches to the model. So making sure that this time around that we have an aligned model for Medicaid, Medicare, and commercial insurers. And that we are accelerating innovations in the state. So this is their overall goal and framework.
Medicare, Vermont has always been on the low end of reimbursement under the Medicare system. So to achieve saving or free them up so that they could come back into the system, are they going to adjust for that historical payment disparity that has existed?
That's a perfect next step to the next slide. And the answer is yes.
Oh, good.
So first and foremost, I also want to take a moment to thank the team. I think it's important who have been working on this. It's not just during the negotiations, but this is work that's been happening for 2 years to both get CMS to have a model that worked for Vermont and now to negotiate what our terms are to see if it will work for Vermont. We are not committing to this model here. I want to be really clear. We are still in negotiations and trying to determine whether this is the right model for Vermont or not. But I'm going to outline the pieces of negotiation. But I want to thank Green Mountain Care Board members, including Dr. Merman and Robin Lunge, and their staff member, Michelle DeGree. And then on our team, we've had folks that we've had Pat Jones, Brendan Krause, Fran Hodgins, all working together on this collaboration, plus contractors that are supporting behind the scenes work particularly Ann Carl. The reason I bring that up is not only to recognize them, but it demonstrates what we, like, this is exemplified what collaboration actually looks like. But the elements of the model, Senator, to your question, is that for the total cost of care, what we've done is we've negotiated a per person per month that is significantly higher. And we've done that because in our initial negotiations with CMS, we demonstrated access issues that our past models and funding from CMS have created. And we demonstrated savings that they've brought into the state that we believe have exacerbated and created some of those access related issues. We've negotiated the savings back into the per member per month that are coming into Vermont. And so there's two things that determine the money coming in, not to get technical. One is the baseline and the other is the year-over-year trend. We've negotiated that baseline up from where what we're currently spending now to significantly higher. And I'll go through the details of how much that is in a second. And so that's the total cost of care piece. Maybe I should just go there.
Well, I think that's really important because Medicare is, obviously, as we're aging, it's going to become even more important. And historically, any Medicare fell back to the federal government,
Exactly.
not to the
So
state.
what we did was we negotiated the savings under our last models back in because we believe that they had created some of the access related and affordability related issues. Here's the detail. It was 2 slides up, but and now I want to note the total cost of care. What we spend underneath that is fluid. So how much we put in the hospital global budgets, how much gets still paid out in fee for service, how much we pay in other areas, all of that. If the trend of those things go up higher than the national trend, it eats into the investment. So what we've presented here is based on this year and where we are currently at, and project where we are currently at in terms of the number of beneficiaries and the costs in 2023. What we've done is estimate how much would be available above and beyond that baseline. Again, we eat into that depending on where we spend it, but it's about $138 million higher than what we currently are spending. In addition to that, there's an additional per member per month that goes to primary care practices that could range in the model from $15 to $21. That's about an $11 million additional investment. And then we get to continue the blueprint and SAT costs at about 10.9 million. And then funding to support SASH at about $12 million over 5.5 years. So these are the investments that we've negotiated back in. I think the first one answers your question, which is compared to what we're spending now, if we trended it forward and everything else stayed the same, we will have the flexibility to determine what to do with what we've negotiated in a higher per member per month basis. Now, if the number of members drops, which could with Medicare Advantage, that will change too. So remember what I said this morning, there's no perfect model. And we've modeled as many of the contingencies as we can here, but there's still some unknowns. Okay, back up, Sarah. Okay, multi-payer global budgets are the other thing. Might as well drop down the next slide. So multi-payer global budgets. I want to remind folks that gives the flexibility of hospitals when their revenue comes in to make choices about how they want to use it. But if they make changes in their line items, we'll have to adjust the budget. So I think Senator Westman had answers in some cases the question you were asking earlier. If the hospitals with their current revenues now are able to make investments, this gives them more flexibility to do that. Now, it's a lot more complicated, as the chair said, but with a hospital global budget, the funding comes in and then the hospital chooses how they're going to use it. So for Medicare and Medicaid, they need to participate in the first year of in the performance year of the program. That could be 2026, or it could be 2027. And that's one of the factors that's still a part of the negotiations, is whether we participate in what CMS calls cohort 1, which is 2026 with our global budgets, or cohort number 2. We are going to, yeah, go ahead.
It was simultaneous.
Yeah, I got 2 questions.
So, to what extent does this include what I call long-term care, which is, it's not only nursing facilities? Is this only hospital-based expenditures?
So I'm going to do a phone a friend, because I would provide you the very non-technical answer, which is it's a total cost of care model, but there are some things inside of the model and some things outside the model. So Pat Jones is here, who's been on the negotiating team. And so I'm going to ask her to both identify herself and to.
Do you want Pat to come up to the table? Welcome to. Grab this chair. Oh, there's a chair right there.
Hi, everyone. For the record, Pat Jones, currently Operations and Project Director for the Department of Vermont Health Access, previously Interim Director of Healthcare Reform. So to the Secretary's point, the total cost of care includes your basic Medicare, Part A and Part B type services. So when we're measuring how we do on the model in terms of total cost of care, think about your inpatient, outpatient, professional services, office visits for mental health and substance use disorder and so forth. The funding that the Secretary was referencing, that additional funding that we might get in terms of investments, that funding would give us the flexibility. And there's actually, in the current version of the term sheet with CMS, there's the expectation that we would use a significant portion of that funding to invest in areas in the healthcare system where we have access challenges, like home health, long-term care, other types of mental health and substance use disorder treatment.
So I think, Representative, what you were asking is, are the long-term supports and services included in the total cost of care?
Home health certainly would be.
Yeah.
Skilled nursing facility services that Medicare, that are currently paid for, sort of in the Medicare Part A, Part B, like your rehab type services.
And so, I mean, we know that in home health, the Medicare rates have been declining and they've been contracting.
Yes.
And so, I guess at first blush, this seems like that could be beneficial to home health agencies. So that's, I guess, one aspect. That's sort of a question, I guess, if that's true.
I think it's a great question. And one of the things that, remember what I said at the beginning, we can have 0 models or 7 models. And we've been looking across the board for different models to support different sectors, the priority sectors. There isn't the one that I'm most worried about, where I haven't seen a model, is for home health.
Mm-hmm.
And with the declines for home health services, this actually one of the areas that they've targeted, because they don't have a way to support home health outside of what's happening at the federal level. One of the goals is to create a target rate to increase home health services in this model, payments in this model.
So, so that sounds like that could be a potential plus on the plus side. I guess one of the things that I'm going to express as a potential concern, if it exists at all, and that's probably partly about, where the potential investments could be made and who would control those investments. I'll just, I'm sitting at this table because of long-term care services and the impact of long-term care services. And I'm not just talking about, for people behind me, not just talking about skilled nursing, talking about home and community services, which is the bulk of where people get their services. And so I'm concerned about more of those services being controlled by hospitals.
Why don't we go, may I make a recommendation, Chair? I think a lot of the questions that are already coming up are going to be answered by us rolling through a very
Okay.
quick 15-minute, like, what is the model and what it isn't. If it's a burning question, I wonder if like, absolutely.
Okay.
But otherwise, let's see if the questions get answered, and they may not, but I think that it might help us more efficiently go through the content.
Yeah. Are you?
Are folks okay with that?
We're fine. Yep,
Sure.
right ahead.
So, for the hospital global budgets, we ramp up participation. Again, this is currently under negotiations, but the term sheet was released today publicly. And we may not land in the same place, but right now it's 10% or one medium-sized hospital in the first year that we participate. In year two, it is 50%, which is one medium-sized hospital and UVM Medical Center. In year three, it's 80% and UVM Medical Center, and then all of the medium-sized hospitals. And year five, the requirement in the current term sheet is 85% for UVM, which would include UVM Medical Center, the medium-sized or PPS hospitals, and the critical access hospitals. We would need by year two to have commercial insurer included. That could be a public plan, or it could be, broader than that. The goal of CMS would be to get as much penetration in both the hospitals and in insurers throughout the model, so we don't repeat what we did in the last model, which is not have the scale that we need to actually have it make a difference. Note, the risk from our last model wasn't, as I just said, was never going to scale. All the providers, not all of the payers were in, which reduced the effectiveness. And so we're trying to fix that. It's what it does provide, it's the flexibility to change services within a hospital global budget. And what I mean by that is many of the recommendations in Oliver Wyman, to tie it back to our earlier conversation, would have had hospitals reduce revenue and reduce services in areas like orthopedics in order to create those the centers of excellence. So it might cause one hospital to reduce orthopedics, but they may decide to increase primary care. One is high revenue, the other is often in the current fee-for-service model of area of loss. This would allow them to keep some of that revenue from the high revenue services to be able to implement the others, but they would need to do a service line change recommendation. And I'll go through that. That's got pluses and minuses to it. And so the changes in those service lines would need to be approved by both Green Mountain Care Board and Medicare. The risk there, the benefit there is that we might be able to more systematically make decisions across our health system. The risk there is the burden nature that we talked about. Okay, Sarah, go back up once. So the other components of our target and investments in primary care, there's a per member per month rate that would go directly to primary care practices. And much of the work that CMS is looking to do in that area would be to continue the approaches that we've been taking in primary care to address complex care, substance use, mental health. And so we really do think that this could both enhance and stabilize primary care in many ways. Then the next one is the investment opportunity in the broader continuum of care. And the agreement includes targets in these areas and as in terms of expectations where we would move some of that funding if it's available. Because remember, like we talked about before, hospital global budgets are in there, but things like long-term supports and services are in there and home health. So if those costs exceed it, it eats into that piece. But the goal would be to, with those investments, to be able to enhance mental health, substance use, home health, and skilled nursing, and then other specialty providers where we're seeing access-related issues. I'm going to go through how the mechanism of that happens in just a second. And then strategies for investing in health equity would also come out of that fund and would be a part of the transformation and health equity plans. So that's a basic overview. And you can see how much that lines up with what 167 had. So, Sarah, if we can go to there you go. think we've gone through this enough, so we won't take any questions there. Ahead opportunities, in addition to what I've outlined, is the healthcare transformation and equity model that's here. That would be an expectation that we're addressing that. Continued Medicare support for Blueprint and SASH, but also the flexibility. We have a significant number of waivers currently under our current model. This would allow us to continue and advance those waivers. Things like the number of days someone needs to be inpatient before they can move to a skilled nursing facility, to streamline processes. Those things have made significant difference in Vermont, and it would allow us to keep those. The one thing about that is that I want to mention that we talked about this morning is AHEAD is not the panacea, and it is not going to address all of our problems. It is a model that has hospital global budgets, primary care investments, and an opportunity to make investments in the joint priorities between CMS and the state. But it doesn't solve all of the, like we talked about home health and everything else. So we're going to have to merge this with other work and multifaceted work that we're doing. Folks have asked about what the timeline is. In March, we submitted the application. In July, we received our notice of award, essentially meaning that we could start the work with CMS and then they would provide funding as we go through the negotiations. Since July, we've been in negotiations and we are still in negotiations. So everything in the parts of the term sheet have not been finalized. If Vermont moves forward, our target signing date is January. So it's right around the corner. And there are two options for participation currently laid out. Cohort 1 is beginning global budgets in 2026 and cohort 2 is in 2027. These funds went. All right. So one of the questions that folks, and this is an area where we are going to continue to do work, is really how does this work? Essentially, we've got key performance targets. So that's the total cost of care. I apologize. Just like for me, I'm searching through the slides. It's in the slides that we were going to present earlier that we've moved back to here. So if we achieve the key targets related to the percentage of participation of the hospitals and the total cost of care targets, we are able to receive additional funds or a bump in the per member per month. The amount of funding that we spend in the broader health system gets drawn out of, it's the difference. I love one of Dr. Merman always calls it the delta between in the total cost of care between how much we spend on everything else and the target. That funding would then move through a hospital global budget and then be directed by the Green Mountain Care Board to move into something that is being called in the model, the East Fund. And it's an equity
access and statewide transformation.
fund. Now, the equity access statewide transformation fund. And some of the work that we have to do over the next year is to work with you all to and with CMS to designate where that fund lives and how decisions are made for funding to come out of that fund. And we've been working with the Green Mountain Care Board to build and put forward a recommendation both to the legislature and to CMS. Ideas include a team that might be composed of members of the board, members of AHS, potentially the healthcare advocate, potentially legislators, so that we can begin to decide how those funds would move and to what projects. One of the things that we talked is when we talk about that, folks are often like, well, it's going to be a grant program. Our conversation about projects that come out of the East Fund are more in line with what do we need to implement to achieve our goals, which might be one-time funds. For example, Rutland needs funding, right? It needs to purchase dialysis equipment. It might be something like that that's one time. In other cases, it could be something, and this is just an example, I'm not saying this is what we're proposing, but it's an easy example, is that Medicare currently doesn't pay for hub and spoke in primary care. It's only Medicaid. And so that's an example of a payment model that would be ongoing, that it could be funded for. And so proposals would come forward related to the transformation, and what's in the hospital transformation proposals, as well as other proposals, to make decisions on that. And the other piece that would come out of that 138, and again, that's how much we project, and it's fluid, for 2026, would be 2 to 3% increases for the hospitals. We could put that would be off the top. And then additional funding could go to hospitals for sustainability. It's not restricted to do that. That would be a decision related to the East Fund. Next slide, Sarah. One more. I want to acknowledge right up front that there are some questions that we either can't or haven't answered yet in the negotiations. They're risks. Is this adequate funding? We can model it out, we can predict it, but I don't know what the increases in the utilization of home health are going to be in year 4. And so whether it'll still be $138 million that we can move. The trend is like that's the baseline. The trend, is it adequate or somewhere in the middle of the model? Right now, Vermont, according to some of the data that Blue Cross Blue Shield has, are increasing at rates that are significantly above the national average. And so if that's the case, if we exceed what's happening at the national level in terms of what we're paying out in some of those other areas, we may not have enough money in the model. I will talk about what can we get out of it, and that's the next slide, but it's something to keep in consideration. Is it adequate funding? And the answer is, for the first few years in all models that we have, it does look like it's more funding than we would receive in Medicare fee for service. But there's some contingencies related to whether we are above or below the trend. The second is, how is it going to affect access? We talked about the flexibility to move things between service line items, but inherently in a global budget, a capitated model can incent a reduction in access to meet budget targets. We've seen that. I just want to be upfront about that. Now, in this model, unlike other models that we've seen, there is a service line change, and so that helps to moderate the access related issue. What are the impacts across payers? So this time, can we get the commercial payers into a hospital budget with Medicare and Medicaid? That's going to be challenging. And do we get to scale? And we've got to watch really carefully. If this doesn't bring in equal amounts of funding or sufficient funding for Medicare, we cannot do what we're doing now, which is shifting over and funding the sustainability of our health system through commercial payment. And so again, if we were to see that, how do we get out of the model? Provider stability, in theory, it provides predictability and flexibilities for hospitals to transform, but it could be overly burdensome to make those line item changes. We believe that this will support transformation by allowing them to make investments in services, allowing them to transition to places of excellence. But it could be if we're not careful, it could be overly burdensome. And then resources. Any model is going to take more resources than we currently have right now. I just want to be clear about that, whether that's reference-based pricing or whether that's, unless we went back to a fully unregulated fee for service. It's right now, we don't have enough staff at the Green Care Board or AHS or in the hospitals. And so resources are an important factor for us to consider in this. So again, is it enough money? How is it going to affect access? What are the impact on the other payers of joining a Medicare model? What's provider stability look like? And do we have enough resources? The good news is we have been able to negotiate an out clause. So the state may terminate the agreement at any time during the pre-implementation period with 30 days notice. In addition to that, if we are in an actual year where we have global budgets, we can terminate the agreement within 180 days. So it's disruptive to the system. I want to be really clear about that. This is a nuclear option, but if it really wasn't working for Vermont, this term is probably the best that I've seen in terms of a negotiation with federal government about getting out. If CMS decides to terminate, we don't want them to terminate overnight, right? Unless it's a joint decision. And so what we have is, depending on where we are in the model, it's between 12 and 24 months of a transition period for them to ramp down with us and end the model. And so that's, again, I don't want to go into a model thinking, it's just like you don't go into a marriage saying, I'm going to start it, but it's going to end. I don't want to go into a model saying that. But I do want to make sure that there's an opportunity that if it's not working for Vermont in our relationship, particularly given some of the instability that we may see at the federal level, we want an opportunity to get out. Okay.
I have one question. And this may fall under some of the existing waivers, but we have MCI investments of well over 100 million. I assume those would remain intact. Okay. Those are expenditures that Medicaid would not otherwise pay for. And it's a significant amount of money. I mean, it's almost comparable to the 138 that you rolled out.
Yeah. So we didn't answer the question about what Medicaid is going to, we've been moving towards hospital global budgets. What we didn't go through is what happens if we don't participate.
We gave authority to do 5.
Yeah.
In the budget.
What was that?
We gave authority in the budget to do 5 hospitals as a pilot.
Yes. We think, given the timeframe that given what last time we entered into a model with Medicare for Medicare, it was rocky in the first year. So what I've outlined here is Medicare's participation. For Medicaid, we're moving to global budgets, and we've been in the process of moving to prospective payments and slowly adding. And so if we don't participate, you might as well go to the next slide, Sarah, but if we don't participate, it becomes insurers could potentially fracture and go into their own models. We would go back to, we're pretty much in fee for service. It's retrospective fee for service, prospective payments, but they're reconciled to fee for service in Medicare right now. Medicaid is on a global budget, and the commercial insurers are pretty much to more traditional fee for service in the commercial market. We would end up kind of staying that status quo. And so this does not impact our 1115 waiver, and it doesn't impact the direction that we are going in terms of Medicaid hospital global budgets. Providers will be subject to, and most of these, some folks will say that these are small potatoes, some would say they're big. Providers would be subject to what's called MIPS and NACRA. MIPS and NACRA essentially means that there will be winners and losers based on how they measure on quality. If we aren't in a model with Medicare. Providers could participate in other models like ACO REACH, but that would not be with an in-state ACO at this point. That model is closed. We could do a Medicare shared savings program, have to be also an out-of-state ACO. Primary care practices would lose their support for Blueprint and SASH unless there's another way for us to fund that. And I think that, Green Mountain Care Board and others may have some ideas of that, but I don't think those are long-term ideas. We would lose Blueprint funding for Medicare practices for both their community health teams and a per member per month. And SASH is almost solely funded through this model. And Vermont would lose access to current Medicare waivers under the all-payer model. So again, there are risks and there are benefits, and there are other models for us to consider. So I'm not here today to say whether we're going to be going in or out of the model. We're still in negotiations, but these are some of the basic parameters that are outlined in the term sheet that we're still working on negotiations. So any questions?
Representative Kornheiser.
Thank you. The
first cohort versus second cohort decision-making in the face of the federal instability, I'll call it. What, how are you weighing those two options?
There's a lot of different opinions on.
Yeah, I mean, it feels like sort of a ridiculous question, actually.
So I think
How little we know.
we want to be able to implement this well.
Yeah.
I think that that's one of the challenges of cohort 1 versus cohort 2 is, do we have the resources and the time to implement it well? There is a risk. We don't know what's going to happen at the federal level. There are potentially enough space for them to try to renegotiate the longer it takes for us to implement that. And that is a
That's
risk
what I was thinking.
that CMS has outlined, that, not CMS, but that our consultants have outlined for us in consultation and having looked at the history. Last time we made a transition between administrations, there was about 12 months that CMS went dark. If we go in cohort 1, we'll be in implementation before the 12-month period. And once we're in implementation, it's unlikely that they would draw back. But they, you know, there are some places where there's discretion for them to make modifications if we don't meet targets. So that's a long way of saying cohort 2 leaves us a little bit more exposed, but it doesn't mean we should do it if we can't implement it well.
I have a couple questions around resources and the timing. So decision will have to be made in early January. We are just back in session on January 8th. We don't have an understanding of what financial resources both agencies will need to be able to implement this. I know part of the money could come from the 138, but it doesn't sound like all of it. So my concern is this 3, and I want to make sure everyone that's listening, because I know we have new members listening, who signs this agreement? Who makes the decision? Is one answer. And then it will, I'm assuming things will have to come to the legislature for approval or to put in statute and for budgetary purposes. And so if for some reason we as an entity decide not to fund the resources you need, what happens?
Okay. Multi-part question.
Yes. Sorry.
First one, there are 3 signatories on the agreement. That's the easy one. It's a Green Mountain Care Board, Chair of the Green Mountain Care Board, the Secretary for the Agency of Human Services, and the governor. And so those 3 signatories are working very, very closely together. The resources to implement is a big open switch. That will be a part of the budget conversations for this next year. We can draw there's not enough money in the what's called the COAG funds, or the funds that are currently coming in. There's $12 million of that to cover the implementation costs, and how we fund it out of the 138, which could be 79 or it could be 138. I want to be upfront about that. Is an open question. So if we don't feel like we can implement it because we don't have the resources, we could pull the plug. So, and there will be things that we need to come to the legislature on. To get to the 2 places that are open questions that we've heard last session, or is it a mandatory model for providers? And is it a mandatory model for payers? And those are open questions that may be something that we need to partner with legislators on.
Make 2 comments. The timing has evolved. We all had anticipated we might have considerably more time. So looking at the models and the finances, you can't predict the future. So how confident are we in the various models? All of them are risky, and not doing it is risky. So where are you comfortable? And then there's the practicality. We talk about providers changing. You can do this. Well, can they get the providers to do it? It's not a light switch. So evaluating all of those things is kind of where we're at. Then even for the resources, we're trying to hire somebody right now. It's taken over 6 months for one person, 9 months for another position. So can you get the people in the door to do it? There's just a lot of unknown, which is where we're all at, trying to assess all this.
And I want to be honest, we're still in negotiations. And one of the points of we're trying to decide cohort 1 and cohort 2. But a point of negotiation is also, do we need to be hemmed into cohort 1 or in cohort 2, or is there something else?
Relatedly about the out clause, so looking back at the all payer model, they're different models, but did we ever know it wasn't working and when? Anyone here know it wasn't working? When did you know? Because I don't think we really knew it wasn't, not that it wasn't working, there were benefits for sure, but it didn't actually work how we had anticipated and wanted. And then second, the politics.
Oh,
Who was gonna say no? I mean, we saw it all the time with the blueprint and SASH money. If you change our budget, there's no blueprint, right? So that is a really tricky thing to walk away from, and also the other support. So the politics around walking out and knowledge that it's not working. Going from theory to practicality and reality on some of these is also just a risk, just like not doing something.
I add to that, also the sunken cost. Like it's going to cost, like to get this model up and going, it will cost systems changes at hospitals. And our willingness to walk away from those sunken costs has been a challenge in the past. So we're trying to go into this eyes wide open with like what we know, what we don't know, but there are a lot of things that we may not know at this point that we don't know. And
Anybody
so-
else?
Go ahead, then I have a question.
I wanted to go back to, you were saying with the global budget concept, then the hospital could determine how money was spent. Without some kind of state plan, and this, I mean, I don't know where the harumph or whatever it's called now. What?
Yeah.
Well, it could very well be that, what would, for example, if a hospital should say, we're going to make that investment here, and we're saying that makes no sense from a system-wide perspective. What will be the oversight relative to, I mean, that's internal to the institution, but would that come under the regulatory authority? Or if you don't, or would we have a better articulated plan in terms of health resources and where future investments need to be made that would guide those decisions? Or is it just the Wild West?
We're gonna go back and forth on this one, because I definitely want Chair Foster to weigh in here. There is a requirement if we participate in HEAD, in having a statewide health transformation and equity plan. And so that the goal is that would be our guiding light at where we would make investments. That is fueled by local health, like transformation and health equity plans. These are not the same as hospital and community needs assessments. And
I'm having a
so,
hard time aligning those two statements with the hospital's ability to take those revenues and use them the way they chose.
right. And so then the second piece is that they would have there's a provision in which the CMS and the Green Mountain Care Board would need to approve any line item changes to a hospital global budget. And that's where I wanted Chair Foster to weigh in. That has advantages because it helps align that, or it has the disadvantage of being overly burdensome. In addition to that, our East funds, which are investments in some of those other pieces, are linked back to those plans. But Chair Foster.
There's one nuance that I think is important, which is, I'm bringing hospital leadership here, but Medicare doesn't cover the cost of a lot of these services for most of our hospitals. A lot of our hospitals lose significant money on Medicare. So my point here is if you just have a Medicare or Medicare and Medicaid global budget, are they going to change any behavior at all? Because they lose money on it. So they're driven by where they make margin, understandably, because in the balanced books. So if you don't have a commercial involved, are you going to see the preventative care change, right? Because they're still going to be focused on the hips and the knees and the colonoscopies or whatever it is that they're getting paid very well on by commercial. So that goes to the point that the secretary made about all payer. And then the other question is, who's going to mandate it? Legislature?
Green Mountain Care Board.
We're all just waiting for the next part of your sentence.
I mean, not us. But let's.
Everyone's looking around.
This is the enduring question, isn't it, right?
So there's that question, like, do the insurers want to do it? Can you mandate it? Who's gonna mandate it? The three sets of people that are here, and same on the hospital side. And then in terms of your question, Senator Kitchell, yeah, it would be a service line change that would come to the care board, kind of akin to a certificate of need process. But then there's a question of, how quickly can you get through that? Right? How nimble can you be? And then you've got to get the feds to do it. And then I think what the secretary is pointing out, though, is this is a lot of moving parts, but if there's were to come to pass, we would need to look at the statewide plan and vision to consider that in light of the service line request. Now, what if the service line request is the pulmonologist up in St. Albans leaves, or making it up, but wherever? Can you say no? They retired, right? A lot of the service lines in our state can be a provider or two at some of the smaller hospitals. So
So the statewide plan and vision, how would I find that document? Not
Not
that I
will
would,
be creating over the next year.
it's yet to be developed.
And that's one of the pieces that, as we said, some of the consultants would be working on. And it builds on the work that we've done with Oliver Wyman.
And built on the work that you'll be doing with hospitals. in the transition.
Exactly, built on the work. So if you take.
I think we're taking a step beyond Oliver Wyman, so I want to make sure that when we say Oliver Wyman, we're not talking about implementing all of those recommendations, but rather we're going further with transformation discussions within and between and among hospitals.
Thank you for the clarity.
Right, well, no,
Building blocks.
I think that people listening, when you say, oh, Oliver Wyman, it strikes a chord of anxiety, and what we're talking about is something quite different in terms of engaging hospitals in their own decision-making, to transform.
That's good.
Representative Wood had a question.
Thank you. So you actually just referred to one of my questions, which was, the participation of a commercial insurer is it's not been forthcoming under the current situation. And so I'm just essentially, nobody has an answer about whether or not that's going to happen or not. That seems clear to me. But, and this is going to feel like an oversimplified statement, but I just feel like I need to make it. Years ago, before we entered into the all-payer system, we were doing that because we had issues about affordability, we had issues about access, we had issues about primary care. We've been through years of this experiment. And I'll just be honest, Vermont cannot afford another failed experiment, period. And so I have not been convinced yet that this is worth the risk or of returning to fee for service, to be honest with you, or some other, I feel like we have, certainly there've been, little blips of progress in certain areas, but as a system, you showed the graphs, both of you earlier, about, where our trajectory has been, and that's with our experiment. And I just felt like I needed to say that because I haven't been convinced that this is going to change that for the better.
It's very hard to predict, as the secretary said, the future. And I think to really try and simplify it, my mind, I don't mean this in a pejorative way, but the gamble or the bet that you're making is that total cost of care bump that we discussed is greater than what you would do in an alternative world and greater than the investments and the time and the commitment to do it. That's where you're placing your bet, so to speak.
Yeah.
Is the cap enough to make up for increases that go with your demographic changes?
Oh, and the administrative costs that you're talking about, which are not known.
Unknown. I mean, what it comes down to me is like, what is less risk, for the state at this point in time? And, I don't know, I don't have the answer to that, but I feel like we need to look at it from that perspective. And, I haven't heard anybody say today, all right, what did we learn from, these past several years? What have we learned about what we shouldn't recreate? What we learned, some of these things that you see there are all things that in various forms or another, things that we have in our current, all-payer model. And So I don't know.
So Representative Wood, I think really good comments and questions. And then one of the things that I think that we learn is that if everyone isn't in, you don't have a large
Right.
enough pool to make decisions and see results. So one of the concern that was just brought up about mandating,
Yeah.
that becomes, that could be a solution to a prior problem.
Yeah. How are you going to mandate a private enterprise?
What,
Okay.
we'll talk to Ledge Council.
Yeah.
To sort of again use the education metaphor, because the balloons. We didn't really like it, just taking one day in this is not gonna shift my brain on that. So, we use the exact same balloon in all of those meetings too. And one thing that's become, and also went through significant other attempts at reforms that did not do it, and perhaps in fact were also inflationary. And one thing that has become just sort of very clear this year, and I think might be clear in sort of when I think about the morning's presentation and the afternoon's presentation, is that you can't fix it with just fiscal reform. You need to also fix delivery reform, right? And it sounds like ahead is much less about sort of delivery reform and much more about it's fiscal reform as a tool to delivery reform, but without the real delivery efforts. And that's like the rubber hits the road and everyone gets angry and we all point fingers and look away. And that's the tough stuff. It's really easy to do mathematical changes because most people don't pay that much attention to them.
Yeah, I think you're absolutely right, Amanda. I want to go back to what I said a few minutes ago. This is the payment side and I'm glad that you corrected me on the conversation about building on our past work. Because this is like, we are taking it as a full multifaceted approach. Again, we need to focus on transformation. That's the systems planning that we're going to be doing with the hospitals. And it's a continuation and advancement of us returning to the fundamentals of where we need to make investments in services that are happening on the ground across the continuum of care.
That's where the plan is.
Well, and I think
exactly
towards what Richie was saying earlier, actually what everyone's been saying, what you've been saying is unless those two things are timed right, we're just gonna make things worse.
Exactly. And so we're starting the transformation now. But I've been doing this a long time and I've made some pieces have worked really well and I've made some mistakes. And some of the mistakes were when we tried to implement models where we actually where we had all the clinical transformation stuff lined up perfectly. Communities were invested, the work was starting, and we didn't have a payment model.
Yep.
And we failed. I've implemented some things where we have been where we haven't had our measures in place. And we've had the payment model and we've had the clinical model and we've failed. And I've implemented stuff where all we had was the payment model, the last model, example of one of them, where we've implemented a payment model and it's not fully population based and it doesn't have scale. And we haven't invested enough in the measurement and the transformation, and we failed. Places where we've done all three, and the simplest and most elegant example are things like hub and spoke. They made tangible differences on the ground. Some of it, we knew what we wanted, we knew what the problem was we were trying to solve, we knew what the clinical solution was, we supported transformation, we had a payment model, and we measured the heck out of it. That's returning to the fundamentals that we're talking about. We can't do ahead without transformation, and we can't do transformation without in some way changing the perverse incentives that we have in our healthcare system. And I'll get off my stuff now, but if there's anything I'm hoping that you've left with today is that our goal in this work around 167 is to try to investigate how we can do all of those three things together, because we are at a critical juncture that this state has never faced before. And if we don't do it now, and if we don't do it with a sense of urgency, and if we don't do it with collaboration, then we are at jeopardy at either losing access or continuing down an affordability space that Vermonters can't take. And so if that's the takeaway from today, is we are working really hard to line those three things up. And this is where, and this is where we're at. And I really appreciate everyone's willingness to come today and ask really inquisitive questions and hear what we're trying to do and to recognize this is hard work and it does have some risks no matter what we do.
But that's a good place to kind of begin to wrap up. I did want to say thank you to you, and did you have a question? No, I just want to say thank you to you and your teams because, and Pat's here, you're part of that team. The work that's been going on is amazing. It's a lot. It's huge, and it will have an effect. Having all of those things go on at one time is, needless to say, extremely difficult. However, it needs to happen. And folks who are in this room and who are remote right now have also been participating and understand the need for the plan first or the transformation at the same time as fund or putting those things together. It's just absolutely critical. Just thank you. No, thank you for your work. Thank you for coming in. We have a lot to do. And I, for one, look forward to continuing our work. It's not always going to be happy. We have some really difficult problems to solve.
Thank you. So thank you.
Thank you.
One more acknowledgement and thank
Sure.
I'd like to thank our providers. Man, they're the ones, I know they're in the room, we're representing them here too today. And thank you all for everything that you've done to get us to this point.
Good. The hard work is just beginning. Yeah. Yeah.